Okay guys, hello. Right, welcome to Pectoral Girdle and Arm. This is a lecture I gave the day before my birthday on the 20th of March 2021. Oh my god, it's 2021. Right, so I want to cover a couple of important things about the pectoral girdle and arm. This isn't to be comprehensive. This is basic science years of medical school, sort of revision primer on what you need to know. So we're going to cover the bones. The wheelbarrow means function, doing things, because there wasn't a muscle vector on the keynote. And the neuron represents neurovasculature, and then we have some clinical cases. So let's begin with a glowing skeleton for the bones. Now, when you think about that word girdle, right, that girdle word, what does it mean? Well, it's actually from the German. Girding means to bring things together, basically, to tie things up together. An old Germanic term. And over time, the actual use fell. It's picking up a little bit now, so it's one of those things where it was a very common word in the 1800s. A lot of people had girdles, fallen out of favour a bit now, but we're still stuck with that terminology, sadly. In reality, it's holding things together, as we said. So I want you to think of this being your pectoral girdle. Pectoral from the breast, it means breast, and so it's holding things onto the breast, right? So you have your clavicle at the front in green, and at the back, the rest of the bones you can see there are all parts of the scapula, and they form the pectoral girdle. Medially, the clavicle has this joint surface called the sternoclavicular joint surface, and if you follow the pin around, we see the acromioclavicular joint surface. We have a medial, we have a more medial to that acromioclavicular joint, an anterior coracoid process, meaning raven's beak. That's palpable, and that's a good landmark because if you move just lateral to that, that is the site at which we do aspirations and intra-articular injections into the shoulder joint. So the coracoid process is important for you to know. And this whole space here is what we call the subscapular fossa, which is where the anterior portion of the scapula articulates with the posterior of the rib cage. And finally, this thing called the glenoid fossa, which is a little concave depression in the lateral surface of the scapula for the articulation of the humerus. Yes. So we have the posterior surface of the scapula now. So we've flipped it around, and we have this the spine of the scapula with the acromion, and the spine separates the space above and the space below, and this is called the supraspinous fossa and the infraspinous fossa, with our spine tapering laterally and superiorly into this acromion. Now, if you know your ancient Greece, or if you just know the geography of Athens, you know that there is a sort of like central-ish portion, which is quite tall, rocky promontory in Athens called the Acropolis, and that's where structures like this little thing called the Parthenon, that's where this lives. So fancy old anatomists said that the highest point of the scapula should be called the acromion, relative to the Acropolis. So that's it in situ. So we have the acromion here, we also have the coracoid process here, and the other thing that we're just mentioning in situ here is that subscapular fossa articulating with that posterolateral rib cage. Let's zoom in so that we can introduce an extra layer of complexity, building things in a spiral way. We have the head of the humerus here, and then two tubercles, the laterally placed greater tubercle and the medially and anteriorly placed lesser tubercle. Now, it is tubercles are outgrowths of bone because muscles and embryological development pull on that bone. So whenever you see an outpouching like that, you can assume that a muscle or a muscle group attaches to that region. Not to be confused with the trochanters of the femur. So greater and lesser tubercle of the humerus, greater and lesser trochanter of the femur. And that's just an arbitrary way of saying that trochanters are bigger than tubercles, right? So this is my rubbish drawing of the boundaries of the joint capsule. Very important because when you look at x-rays and you look at fractures and damage to the proximal humerus and the glenoid region around here, if the fracture or damage occurs within the actual capsule, then it has significant complications and significant implications for avascular necrosis and the types of surgical fixation that is performed. So you note that the joint capsule runs laterally between the two tubercles, so it attaches to both tubercles. It attaches around the boundary of the glenoid fossa, and there is an inferior sort of like herniation of that joint capsule down here, and that is so there's a bit of laxity, a bit of space, so that when you abduct the arm outwards, it doesn't rip, because if that was quite tight, quite taut, then when you abduct it, it would rip. So we need a bit of laxity, we need a bit of give in the system here. And this is what it looks like on a better illustrator than myself. This is the joint capsule, and there's one of the ligaments. So quite a few ligaments here. You don't need to know the names of these ligaments, but what I will draw your attention to is obviously the acromion process here, the coracoid process here, the clavicle here. So the articulation between the clavicle and the acromion is called the acromioclavicular joint, and it has an acromioclavicular joint capsule. The coracoid attaches with several coracoclavicular ligaments and also articulates with the acromion here at the coracoacromial ligament. Right? So those are the three steps you really need to know, and then these you don't need to know so much. For example, the transverse humeral ligament is not really what a med student needs to know, but it's the roof of the cave that holds this tendon here, which is the long head of biceps tendon, which is going to attach on the supraglenoid tubercle. Don't worry too much about that. So surface anatomy is how you're mostly in practice, unless you're an orthopedic surgeon, going to approach the shoulder. So this is what you're actually going to see. So you've got your palpable clavicle and your palpable acromion at the back, coracoid in front as well. So let's peel the skin off, and there are 5 sets of muscles. Pause the video here and tell me if you can name these 5 muscles, basically. So we've got platysma, pec major, biceps brachii, deltoid, and trapezius. And then here's the rotator cuff. So this is a rotator cuff, which is a set of muscles that literally is involved in cuffing and protecting that glenohumeral joint and holding it in place. And I've outlined the 3 clearest ones that you can see here. Pause the video and see if you can name them. So that's supraspinatus and infraspinatus, as well as teres minor, but we'll come to that in a little bit more detail, because what I want to do now is build up this picture of complexity together. So rather than seeing those muscles in isolation, we're going to see them now in situ. So here is a rotating shoulder, right shoulder. So let's start with the osteology. So we have the clavicle articulating with the manubrium here at the sternoclavicular joint. Laterally, we have the acromioclavicular joint here, and then here's the coracoid process. Now note that the coracoid process is very palpable, very anterior, which is nice, so we can feel it. If you move lateral to that, your injection will hit that glenohumeral joint. So that's a really good anatomical point. This coracoid process has about 4 really key attachments you should know. You should know that there are a combined set of ligaments with different names, but just learn the combined complex. This is the coracoclavicular ligamentous complex. Then you've got the coracoacromial ligament, which we're going to mention in a second. You've got a head of biceps here. So there's the short head, and here's the long head, which actually enters the joint capsule to reach the glenoid tubercle. And then you've got this muscle here called pec minor. So we've taken pectoralis major off to see pectoralis minor, and that attaches to the coracoid process here, as well as ribs 3 to 5 classically, more anteriorly and medially. Just a sip of my coffee there. So let's rotate this model a bit more laterally, and we can see the rotator cuff here. So here is subscapularis attaching anteriorly here, and then we have supraspinatus and infraspinatus, and look at this really clinically important course of supraspinatus. So here's our spine of the scapula, and then we have the acromion. And supraspinatus, coming from the supraspinous fossa, runs to this greater tubercle on the humerus. Okay? So it will serve to abduct the humerus. But notice that it has to travel under an arch formed of the acromion, the acromioclavicular joint, and importantly, this coracoacromial ligament. So if we have any swelling of the muscle or the ligament or a bursa, which is a fluid-filled lubricating sac between the two, then we're going to have an entrapment syndrome there. Let's just zip round to the back. So we've said infraspinatus. This muscle is teres minor, and beneath it is teres major. Now note that teres minor because it's smaller, teres major doesn't attach where teres minor does. Teres minor here is going for that greater tubercle, but teres major actually inserts at the front. That's teres major. So it's coming to the front, not to the back. So they have different functions. They sound the same, they start at the same point, but they have different roles to play. So that's very well worth bearing in mind. So let's formalize what we've just covered there and say that supraspinatus runs from the supraspinous fossa to the apex of the greater tubercle. And because it hits the top, the apex of the greater tubercle, like a pen here, if I attach to the top and then pull, I swing it out. So I cause abduction. And it will be the initiator of abduction that deltoid will then take over. So the initial abduction is supraspinatus, and then deltoid takes over. Infraspinatus, lying in the infraspinous fossa, goes to the posterior greater tubercle. So it's further at the back. So instead of doing that pendular swing, because it's at the back, it spins. Okay? So this causes lateral or external rotation of that glenohumeral joint. Teres minor, lying below infraspinatus, with a similar course attaching to the same point, does a similar function. Okay, so it's from the lateral scapular border. It runs to the posterior greater tubercle, and it forms a lateral rotation of that glenohumeral joint. So what about subscapularis? So this runs in that subscapular fossa. Okay, it goes to the anterior part of the lesser tubercle, and you can imagine that if you contract this muscle and pull the apex of that triangle to its base, it's going to pull in the humerus, and it's going to swivel it in, okay? So it conducts medial rotation of that humerus. So that's a structural overview. So let's just review the function of your shoulder and what's going on here. So this action here is flexion. And what I've done is dissected away all of the structures that are not muscles that help pull that humerus forward. You can see, just based on the anatomical location, how all of these muscles, if they contract and pulled up and forwards, would cause that flexion. So we have pectoralis major that helps to flex, as does deltoid, but the primary flexors of this shoulder joint here are the anterior arm muscles. Okay? Then the back has muscles on the back, and there's a couple that you really need to be aware of. Latissimus dorsi, this giant hugging muscle coming from the thoracolumbar processes and fascia and running to the humerus from behind to the front, grabbing and pulling the humerus backwards, as well as teres major, like we mentioned before. And the posterior portion of deltoid also functions this way. So note that deltoid does both flexion and extension, depending on where it is. Okay? So, this is abduction. We've already touched on this, and we have a lovely illustration here. So here's our spine of the scapula, acromion process. We have supraspinatus running to the apex of that greater tubercle, and then we have deltoideus, or the deltoid muscle here, attaching to that deltoid tuberosity on the lateral midshaft of the humerus, and that will cause abduction. So supraspinatus initiates, and then the rest is taken over by deltoid. A common exam question. And there's assistance from others, but it's supraspinatus and deltoid you really need to remember for the exam and for clinical practice. So this action here that this guy is performing, when I can get him to do it, this is medial rotation, right? So this is the same as this. And your medial rotators are pec major from here, grabbing it and pulling it in, latissimus dorsi from behind, grabbing it and pulling it in, teres major from behind, grabbing it and pulling it in, and then subscapularis coming, grabbing that medial, lesser tubercle, and pulling it in. Okay? So these are all the muscles involved in medial rotation. And then here we have a lateral rotator with a resistance band. So this is the role of infraspinatus, teres minor, and deltoid. Now I've removed deltoid so you can see infraspinatus coming from the infraspinous fossa, and then teres minor. So, neurovasculature. Very briefly, let's talk about the axilla. Now the axilla, the armpit region, runs from the lateral portion of the first rib to the inferior border of that teres major we've mentioned several times. And this whole area is the axillary artery and vein. So when the brachial artery runs into this portion, When it hits teres major, it arbitrarily becomes the axillary artery. When the other way around. When the subclavian enters, it becomes the axillary artery, and when the brachial vein enters, it becomes the axillary vein. So we have the coracoid process here, which is the attachment for pectoralis minor, and pectoralis minor divides this axillary artery into 3 regions: a proximal, a middle, and a distal, and they all have different named branches coming off them, which you don't really need to know, if I'm honest with you. Some medical schools make you learn it. Warwick are not one of them, fortunately. Just bear in mind the drainage of the superficial veins of the upper limb. This is a common exam question, and it's labelled colour-coded here. So the cephalic vein here, this lateral cephalic vein, drains into the axillary artery, the axillary vein within the axilla, but the basilic vein joins the brachial vein. The basilic vein is this big vein here, and it joins the brachial vein at teres major to become the axillary vein. Okay, cephalic dumps into the axillary, basilic dumps into the brachial to form the axillary. So they have different termination points. So you could be asked, what is the termination of the cephalic vein? Which of the following drains empty into the axillary vein? Kind of situation. So just make sure you know those boundaries from the first rib to teres major, with pec minor in the middle, and then the course under pec minor of the axillary artery and vein, and how those superficial veins drain into each other. Now I'm going to cop out here, because normally we talk about the spaghetti that is the brachial plexus. There simply isn't enough time. So what I'm going to say to you is, I made a video in my for my CBL group in phase 1. Please watch that video. I will enclose a link. 15 minutes tells you everything you need to know on a whiteboard with models and muscles about the brachial plexus. Now I do just want to quickly mention 3 nerves. I know you had an upper limb and lower limb nerve injury, but we do have to mention these for the shoulder because they are really important. So the first schematic you can see here is the axillary nerve, and it has motor and sensory functions. It comes from the brachial plexus here, runs in the axilla, which we said is from that lateral rib to teres major, runs along here, and then notably gives a branch to teres minor here, and then runs behind the surgical neck of the humerus. So a common site of fracture of the proximal humerus, so you need to bear that in mind, runs behind here to innervate deltoid. So it's going to supply deltoid for motor, teres minor for motor, and then it sticks around here to supply the regimental badge region. So you can have a regimental badge sensory loss, basically near the region where you get your COVID vaccine shot. Okay? And regiments are often, their badges, their insignias are often placed out here, or they used to be. This is a Canadian example. So that's the sensory loss. So loss of deltoid, loss of teres minor. So think back, what functions do you need to test to assess axillary nerves, sensory and motor supply? Moving on to musculocutaneous now, nice and quick. Musculocutaneous supplies the anterior arm. 3 muscles for the anterior arm: BBC, biceps brachii, brachialis, coracobrachialis. All musculocutaneous. So it supplies the anterior arm muscles, and then a bit roadly, because it's musculocutaneous, it has a cutaneous supply to the lateral forearm. So it carries on into the forearm here as purely a sensory supply. But we don't need to worry about lateral forearm because it's my job to teach you about the shoulder. So that's the flexors of the shoulder, musculocutaneous, BBC, 3 muscles to remember there. And then the final one, the more complex one, the radial nerve, this runs for a time at the back of the humerus, okay? So it runs in the spiraling groove of the humerus posteriorly. It supplies the posterior arm muscles to all extents and purposes, although it's also anconeus and brachioradialis. What we're really concerned about here is triceps brachii, okay? So triceps brachii causing extension of the elbow, okay? So it's really important that you know triceps brachii here. So a couple of pictures of the radial nerve. So you can see the radial nerve running here and then running in the posterior spiral groove to the lateral aspect of the elbow. So just make sure that you are familiar with that occurring. And there you can see it running deep to triceps. So we'll just quickly, with a couple of minutes remaining, do some clinical stuff. So clavicular fracture is one of the things you really need to know. This stuff will serve you well because this is how the shoulder is commonly seen in clinical practice and is really important for the remaining phases. Here's your clavicle, fractured right down the middle, okay? So, a couple of key questions. Which bone is broken? The answer is the clavicle. How would a clavicular patient present to you? Now, I do want you to go back and have a look at this on the video because we don't have much time, but there is a mnemonic called B-slip duct, the common presentation of a fracture. Bruising, swelling, loss of function, irregularities, pain, deformities, unnatural movement, crepitus, and tenderness. So if you think a patient has a fracture, work your way through B-slip duct, and if it's got a couple, you've got a high index of suspicion that it does have a fracture. In the clavicular fracture itself, okay, the medial clavicle rises because sternocleidomastoid attaches to it and pulls it up. So you'll have a sort of like an indentation under the skin if it's not a compound fracture and sticking out of that. Which is the most common fracture site? 80% occur in the middle third. And the reason I'm totally banging on about this is because the clavicle is one of the most commonly fractured bones in the body. So it's really important that you know this. And so likewise, why do we care? Well, because there are a lot of structures. We said that the axillary, artery, and vein run behind it, right? They run behind it. As does the brachial plexus, and there's the apex of the lung, which has a pleura called the cupula, a pleural lining over the top of it. If you have bony fragments that pierce that, patient can have a hemopneumothorax. So it's worth bearing that in mind. Now, subacromial impingement syndrome we already touched on. Do you remember that the supraspinatus muscle runs under that arch of the acromion, of the clavicle, of the coracoacromial ligament, and then that bursa, that fluid-filled mass, that fluid-filled sac? If any of that's inflamed, then you will get pain on abduction, okay? But it's important that this is later abduction. So it's not when supraspinatus is functioning, it's when deltoid is functioning. And that's because if you have subacromial impingement, it's when you elevate higher and higher and higher, and supraspinatus rises in that arch, hits the top of the arch, or hits the bursa. That's when you get the pain of subacromial impingement syndrome. So that's the cause of supraspinatus, and an inflamed bursa is a common cause of that. So it's well worth bearing that in mind. Another quick one that comes up is something called calcific tendinosis or calcifying tendinitis. And this is where it looks like there's bony fragments in the tendon of supraspinatus. And there's basically calcium deposits. I like to think of it as a sort of like gouty-like thing of the shoulder. You can palpate the stones of calcium and you get very focal pain. It's very sore, very tender. And you go in and you literally aspirate it. You pull them out. Frozen shoulder, adhesive capsulitis, you'll have heard of. This is where you have an autoimmune picture. Patients got celiac, thyroid disorders, IBD, rheumatoid arthritis, what have you. And there's been just chronic low-level inflammation that has damaged and scarred the joint capsule. And it's just painful. They get night pain, rest pain. They can't move it much. Adhesive capsulitis, that glenohumeral joint labrum isn't doing so well. And then we come to the rotator cuff tear. So this is classically what you say on the tin. Here's a supraspinatus, and then here's a schematic of an infraspinatus tear. So you do several different movements to try and elicit them, and I've put a couple of them up here. You have the empty can test, which tests for supraspinatus damage or impingement. You can do medial rotation, testing some muscles, and lateral rotation. So make sure you go back and know exactly what external rotation tests, infraspinatus and teres minor, and medial rotation tests, subscapularis, teres major, right? And then initiating abduction is the role of supraspinatus, and then up here is the role of deltoid taking over. So just a quick one-liner about the presentation of each of these. Clavicular fracture, B-slip duct for every fracture, bruising, swelling, loss of function, irregularity, pain, deformity, unnatural movement, crepitus, tenderness. The medial clavicle rises, the lateral falls. Subacromial impingement syndrome, where that arch has something in it that is going to compress supraspinatus as it rises too much. Calcific tendinosis, when calcium deposits, palpable, you can feel it, and there's localized pain in that region. Adhesive capsulitis, these patients have stiff movement all around, usually a middle-aged female with an autoimmune picture because they're more predisposed to it. Rotator cuff tear, okay? It will occur spontaneously in older people or through major trauma in young people. More young people or fit people are more suited, as you would imagine, for surgical repair and good outcomes, therefore. So that is the pectoral girdle in the arm. Thank you for watching. What I will just remind you is we have nearly 3,000 questions now on medguide.uk, all tied to Warwick Med School learning outcomes. Do check it out, and please scan the QR code here, feedback form. I like to make really short feedback forms. It'll take you less than a minute to fill it out. Thank you very much for coming. I'll leave this up on the screen for a couple of minutes or so. And if there's any questions, do let me know. Send me an email, or you can ask me in the chat now. Thank you.